So hello, everybody. Welcome to Coffee and Conversations. I am Jess Carson. I'm the director of the Carsey School of Public Policy's Center for Social Policy and Practice. I'm research faculty here, and I am joined this morning by Rebecca Ross, who's the director of the Bureau for Children's Behavioral Health at the Department of Health and Human Services for the state of New Hampshire. We're very lucky to have Rebecca here with us this morning. I'm so excited to be able to talk to her, to have you all with us, and to hear more about Rebecca's really exciting work at this really great time in the state. And so I'm hoping that Rebecca could maybe kick us off telling us a little bit about herself, about the Bureau, and about the work that she's doing. Rebecca, if you have some slides you want to share, that would be a perfect way to kick us off, perhaps.
So to start with, again, I'm Rebecca Ross. I am the director of the Bureau for Children's Behavioral Health here at the department. I've been in this role since January of last year, so about a year and a half. Prior to this role, I was general counsel and legislative liaison for our Division for Children, Youth, and Families, and spent a little over a decade before that representing HHS and other state agencies as a senior assistant attorney general at our Department of Justice. So I've worked in both mental health and child welfare for the majority of my career here in New Hampshire. And this was a great opportunity to continue the forward-facing work that the department's been doing. After these slides advance. So to put it into context a little bit, before 2016, we didn't have a Bureau for Children's Behavioral Health. We essentially had services either through the private service system, our community mental health centers, or the Division for Children, Youth, and Families. So in order to access high-end services like residential or intensive in-home services, a family had to be court involved. We have shifted that, and we'll talk about that a little bit more later, but we essentially didn't have a cohesive system for children's behavioral health throughout the state that was integrated. As we've built the system, we've essentially identified 5 tiers, starting with tier 1, which is assessment, screening, and really early treatment, the services that you might see anywhere, either in schools, primary care offices, community service agencies, but knowing that mental health is not just mental illness or the identification of a disease, but something that we all have. We have physical health, we have mental health. Sometimes it is well and good, and other times there are needs that need to be addressed. So tier 1 looks at everyone's needs, hoping that we're starting with prevention and earlier intervention so that we don't end up in the higher tiers. And the tier 5 goes all the way up to our acute psychiatric care, where we've seen a lot of changes in the last couple of years. And that highest intensity need is the smallest portion of our population. Oh, I apologize. I think it just stopped sharing for a second. Did it?
It did stop sharing. Yeah, you can maybe see if you can share again.
Yeah, let me get that going again. There we go. Perfect. So the big takeaways on this are that we've intentionally created a system starting in 2016 to serve all children and families and move it away from court involvement. To do that, well, here's a little bit more of the timeline. That in 2012, we did a single pilot project. It's really where it started within DCYF. As we've progressed, there's been a number of different state and federal initiatives. In 2016, the Bureau was created, and now what we'll talk about are all the different programs that we are either part of or directly responsible for. We do sit within the Division of Behavioral Health, which also includes adult mental health services, the Bureau of Drug and Alcohol Services, and the newly added Bureau of Housing Supports, which helps with the integration throughout the lifespan and understanding that mental health and substance use needs are very intertwined. So we are intentionally trying to build those services together to meet families across the lifespan. Our particular bureau is made up of 9 positions or 9 individuals. So we are a small bureau for a statewide program, but we have 3 distinct components: our system of care administration, which is our first tiers 1 and 2, and our acute system, and really the integration and work between other divisions, other departments, and all of our providers and stakeholders. Our intensive community resources are our tier 3, that includes a lot of our high fidelity wraparound and in-home supports, and then the transformation for our residential system, and supporting both court involved and voluntary services in a residential capacity, which is new in the last couple of years. So a little bit more on the statutory history. In 2016, the Bureau was created, and the enabling legislation for the system of care that incorporated both Department of Education and Department of Health and Human Services was enacted in 2019. There was a major expansion, which also came with the appropriations to start doing a lot of the work that we're really just starting to see and feel now. That included the statewide mobile crisis. It included the residential transformation, universal assessment tools that we can talk a little bit about. And then in the last couple of years, we've had a couple smaller additions to the system of care, but 2019 is really the bulk of the work that we were given the funds for and mandated to stand up. Of course, the timing was very interesting because we received it in 2019 and shortly thereafter the pandemic hit. So all of this implementation was done in less than optimal circumstances, and certainly impacted the way we rolled things out and what we were able to do during that time. So I have a little bit more about the different drivers. We had that system of care legislation that I just talked about, but there was also federal legislation, the Family First Prevention and Services Act, that shifted the funding streams for treatment from residential and out-of-home placement for youth in foster care to focus on prevention services and ensuring kids are able to stay in home unless absolutely necessary. We had our 10-year mental health plan, which was a statewide initiative that for the first time, this plan included both children and adults. The prior plan in 2008 only included the adult population and services. So that was a big step with all of our stakeholders and a long process to create that, to have a vision for children being served as part of a larger mental health system. And there's been substantial work through the juvenile justice system as well to ensure that needs assessments and community sports are connected and identified before a petition can be filed by law enforcement to ensure the smallest number of youth are reaching the deep end and becoming court involved when what they really need are services and supports. So taking all that into account, that drives where our Bureau puts services together and tries to meet all of those different goals and outcomes in a consistent way. What's nice is they really are all in alignment. So it's been exciting to have support from so many different directions as we've tried to really transform our behavioral health service delivery system. The last slide that I'll go through before we start actually having a conversation is just a recognition that in the statutory framework, the children's system of care is intended to serve a lot of different populations of children and youth, including the CHINs, the children in need of services, juvenile delinquency, child protection, special education population, children served through mental health services, the developmental services system. And in 2022, in Senate Bill 444, there was an expansion to children birth to 6 who had been exposed to ACEs. And so really, we're covering most children through the system of care that may have a unique or individual need throughout development. And that was very intentional as the system of care was established by the group that came together to propose the legislation and drive it forward.
Fantastic, Rebecca. Thank you so much for bringing us through some of those kind of overview of the structure and also the timeline, which I think is really important and opens up a lot of questions around, what this implementation of all of these moving parts has been like for the Bureau, particularly given the timing of the pandemic. And so I want to ask you about some of those elements too. I'm keeping an eye on the chat and the Q&A for us, but I thought first, maybe I could ask a question or two as folks are having a chance to collect their own thoughts and contribute some questions. So I love the note that you sort of explicitly called out that mental health is not just about mental illness, but that I see this kind of prevention focused thread going through all of the work that the Bureau is doing. And I wonder if you can tell us a little bit about kind of what shaped that approach and, how the state has come to recognize the importance of a prevention focused lens when thinking about children's behavioral health.
Sure. I think there are so many drivers, including those 4 big drivers that I mentioned, knowing that on the juvenile justice side, a lot of the behaviors and the conduct that we see that end up in the juvenile justice system are really demonstrations of unmet needs. And that if we can do a better job assessing that, we can identify those. I think the same is true in child welfare, as well as the number of individuals that have been reaching out for help as we've gone through the pandemic, and we've worked to decrease the stigma and to have that recognition that everyone may have needs sometimes, and addressing them as they arise is going to be less disruptive to everyone's lives. It's going to keep parents at work and keep kids engaged in the community. And that if we start that conversation early, that we're really only going to see the kids that have the highest needs and the deepest end of the system when we could have addressed them earlier. So working with public health and primary care providers, a lot of the work that's happened in schools during this time has really brought it all together. One of the things that we've done is, well, and I should also mention all of the ACEs work, all of the research over the last couple of years that's shown that all of these traumatic experiences that young children are exposed to impact both their physical and mental health and their productivity and their projected lifespan later in life. That if we can identify and mitigate early, we are going to have a lot less cost later on, both social costs and financial costs. And so working all of those in, what we've tried to do is identify a universal assessment that is the CANS, the Child and Adolescent Needs and Strengths Pool, that we are incorporating into every level of the system, so that we can really look at what the needs are and what the strengths are, and not just of the individual, but of the whole family, and meet those needs before there's a diagnosis, before it's so impactful that it's disrupting normal everyday life. And so we have had to focus on the deep end services too, because prevention also takes time to see the results of, but having the same tool being used by our residential providers and our acute psychiatric hospital as we have in our community mental health centers helps everyone have the same conversation along the way and really understand the family's needs as they progress over time.
That's a great point. And I can see your background in child welfare sort of coming forth, and the recognition of how important these prevention focused pieces are, the importance of tools, and sort of having those shared conversations across systems. That understanding of cross systems workings, I think, positions you really well to be at the head of the Bureau, especially, as these elements are sort of taking shape and lifting up after having the foundation put in place. I see we have a couple of questions coming in the chat. I want to pose maybe one more question to you as those questions are accruing in the chat. And that is, just the elephant in the room of the pandemic and how that kind of shaped what you're seeing as a Bureau, and And, luckily, I think the Bureau did have many of these foundational pieces in order pre-pandemic. This wasn't necessarily reactive, but I can't help but wonder, how did this all sort of shake out for you? Were there pieces in the policy landscape of the pandemic that were supportive of the work that you were trying to do? Were there pieces that were making the implementation of all your sort of planning difficult? If you could talk a little bit about that pandemic side, I think that would be really helpful.
Sure. I think there were individual impacts to children and families and system-wide impacts. Because we received that funding and had a plan and had a direction in 2019, we were in a much better position to pivot and meet the needs of children and families in a different way, because we'd already had some of the planning in place, even if it wasn't fully implemented. So for example, our Fast Forward program, which is the New Hampshire's high fidelity wraparound that also includes peer support and clinical services, and for the older youth peer support, has a lot of different components beyond just a regular clinical service that really works on supporting families and teaching families how to use their natural resources and community providers when things arise. We had done that work. That was our first pilot, and we had projected when we did our Medicaid state plan to serve 150 families a year through that service. We're serving well over 500 now. So we had the training in place. We had a framework. We've brought more coordinators on board, and we were able to expand that capacity to serve more families in the home. As we went into the pandemic, residential providers had quarantines in place. They had delayed admissions. They had workforce challenges and still do. So admissions were slowed down. More kids were identifying with higher needs as they were isolated and losing their normal supports in school and community activities. So as we saw demand go up, we were able to continue to build out our intensive in-home supports, some of which we were able to shift to provide virtually. So families didn't feel like somebody needed to be in their home and increasing risk, but they could still connect with those supports that they needed, particularly that family peer support. Our families may be experiencing something they've never gone through, and the youth peer support to have a young adult connecting with that youth to make sure they weren't feeling alone, to have shared experiences. And so while we had some framework, we still had some catch up. We still do. We still have more demand and are continuing to bring on coordinators. But we did not see, the same way other states did, increased numbers in our emergency departments. We still had the wait list, but we didn't have the spike that other folks did. And I apologize, my light sensors don't get activated for my desk. So we could still serve them in other ways. And then adding the flexibility of telehealth and some other things throughout the pandemic just made it that much easier to keep staff on board at our community agencies that were providing those supports. That's not to say there's not still unmet need and wait lists with community providers. We're very realistic that we have a long way to go. We expect a system of care transformation to be a 10 to 20 year process. We're not 10 years in and had some serious bumps along the way with the pandemic, but we're really excited about the families we were able to meet their needs and minimize those impacts.
That's great. And hearing, how much having those pieces in place sort of helped maybe stem some of the pressures on the system, I think is really fortunate for New Hampshire that we didn't end up in the position that many other states face, which was, of course, the intense pressure on the emergency rooms and having, not having put this sort of thought and groundwork in place in advance made it, I think, all the more difficult for those states. We have a couple of questions in the chat. Pam Stiles asks, will you talk a little bit about how the implementation is going, given the challenges in finding providers to deliver services? And have you found any creative ways to address the lack of providers?
So with our care management entities, I think that we have been very successful in finding workforce. They're exciting jobs. It's a new way to provide services. And I think that what we hear back is folks feel empowered to meet families' needs in a different way. So that's one place that I think we're attracting workforce and they're growing and finding success. But that doesn't mean it's not a drain on other parts of the system. We're working across the board through the department for all of the workforce issues. We would certainly like children's behavioral health to be an area that people are excited about and want to go into. It's very disappointing when you're at a meeting and people don't know that we've done all this work, and the counsel to folks going into college or coming out of college is, you don't want to work in children's behavioral health. There's no opportunities. We are creating different opportunities all the time, trying to make sure that training is transferable and desirable. So I don't think we're going to see all of the benefits of that for a while, but I think we're very intentionally trying to create transferable certifications and skill sets and an environment that is exciting, because people are in this field because they want to help people and they want to feel good about the work that they do. And to know that there is opportunity and you'll be able to pay your rent is important, because even if people want to, sometimes they can't. And so we're working on that. One of the exciting things that we're doing on the crisis side is our rapid response, which includes our access point, which is phone, text, chat, and then our mobile deployments from our community mental health center teams. We're working to create a universal certification for that, to change the teams from a master's level clinician and a peer to 2 certified responders, that hopefully individuals who are going through school can get that certification and continue to work through school, see the opportunities in the system, have that count as they continue their education and professional development. So it's opening up more opportunities for workforce earlier, and then making it something they can build upon. So hopefully we're going to be rolling that out and partnering with our academic institutions in September. It's on a really fast track to do that, because we know we don't have enough master's level clinicians to meet all of the need of those mobile deployments, and want to use them in the most effective way throughout our system. And there's a number of other conversations about ways to do that as well, but I think we're really intentionally trying to make sure that we're building it to not just pull staff from one place to another and continue to have that back and forth.
Yeah, I love that approach. I think we're seeing more of that across sectors, and often in many sectors that are serving children and families, that there has to be this intentional building of a pipeline towards careers and towards sort of reorienting how people understand the opportunities that exist in those sorts of professions, and those smaller credentials and those building those pathways out are maybe the sort of slow and steady version, but they have seen a lot of success in doing that. And so maybe it's not the answer tomorrow, but in terms of sustainability and longevity, that's a really sort of creative way to think about how to build up that workforce and sort of carry that forward. Dennis asks, medical doctors use physician's assistants more and more. Being a licensed practitioner requires a lot of time and work. Do any states have paraprofessionals who can step in?
Absolutely. We have certifications at all different levels. We are intentionally bringing in a lot more peers into the workforce too. So individuals with lived experience, whether they are on the substance use or mental health side of the experience, lots of times it's combined, but looking at using peers and paraprofessionals in a number of different ways. And we certainly are seeing that within our community mental health centers. And again, that's exactly what we'd be looking to do on that crisis certification training, and looking at supervision, looking at all of our administrative rules for Medicaid, whether it requires the highest level of medical licensing or a nurse practitioner, or what level is consistent with Medicaid regulations and quality service. And there have been a number of changes in the regulatory legislation through the OPLC, Office of Professional Licensing and Certification, that everyone is looking at and asking the question, where can we use different skill sets and what's the most appropriate? And so I think we continue to ask those questions and make small changes along the way, and design the new things with that very much in mind.
Yeah. I'm glad you pointed out the Medicaid issue, because I think that is a question, right? That you are often constrained in your choices of who can provide what services because of insurance requirements. And I wonder, can you say anything about sort of the changes that we maybe are seeing, or are we seeing the changes that are moving in the directions that would be supportive of this sort of broadening of the workforce and sort of enhancing the flexibility that you all have in the ways and the opportunities you have to deliver services?
Yeah, absolutely. I think that from the federal side of things, we're very much seeing a focus and support for using more peers and individuals with lived experience to support families when it's appropriate. We are seeing the federal side looking at all of those requirements too, including, the use of nurse practitioners in our institutions and essentially every level. I mean, I think the key for us is everything we're building is individual and family driven, and that we are looking much more at a team approach. And so identifying which parts of the team are best suited to provide which type of supports, and getting away from a clinical only model where everything starts and ends with a clinician who can be doing intake, who can be answering the phone, who can be having that first face-to-face engagement. We're having to ask all of those questions.
Mhm. It's nice to hear all the different parts of the process that can be dissected and sort of, examined separately in terms of places for policy shifts or practice shifts, although that's certainly an intensive process. There are a lot of layers to that. And I don't think that we should let that piece go unrecognized, just the sheer volume of that planning and that process of implementation must be a huge lift, particularly on a moderately sized bureau like yours. I'm curious if you can say a little bit more. I've heard you mention peer support a couple of times. I'm curious if you can talk a little bit about that as a model. I mean, I think peer support and telehealth, those sorts of approaches came to maybe a little bit more public focus during the pandemic, but we haven't always heard them thought about in terms of children and families and, children's behavioral health. And I wondered if you could say anything about the ways that those kinds of models might be different when we're talking about children's behavioral health, or, what some of the successes or opportunities might look like when serving this population.
Sure. I think, we're looking at peers as a critical part of every part of the system, and that peer role may be different depending on what part of the system you're in. So we have had peers in the child welfare side with Better Together and parent partners, who are people who lived through the experience of having BCYF involvement in their family, and they come and talk to and work with other families who are going through it to help them find success. We have amazing partnership with NAMI, who supports our family peer support through our care management entities in the Fast Forward program, and now our 0 to 5 enhanced care coordination, because we just launched the component that focuses on early childhood for that same model. But we're also building in, for example, at Hampstead Hospital, we launched the psychiatric residential treatment facility, which is a level 5 residential, our first in New Hampshire, a couple of weeks ago. Prior to that, we had to go out of state for that level of care. One of the key positions is a family advocate. That essentially is a type of family peer support, someone with lived experience to help families with what they need, both to support their child while they're in residential and put in place the pieces to return home. Because we know when a youth returns home, not only does the youth need support and the right services and the right plan in place, but so does the family. It's not just the parents, it's the other children in the home, and we have to look at that whole dynamic. So adding a family advocate in as a critical position in the PRTF will help provide that, and then connect with other peer support back in the community. So I think we're looking at it at every different level, where traditionally it was community mental health centers have peer support for individuals served there. We're expanding that very much. In addition to the crisis responder certification program, we're also looking at expanding our crisis model has been based on the crisis now model, which is someone to call, someone to come, somewhere to go. We're building out the somewhere to go. We're looking at standing up to 23-hour or less crisis centers that will serve families. So they have to be prepared to serve across the lifespan. And it will be much more of a peer model than a clinical model. So using those peers to support families as they're there, connect them with the services back in the community, and support all parts of the family when a child or youth is in crisis and just walks into these crisis centers. I think it is an integral part of every level that we're building.
What an important resource, and seeing that built out and that sort of echoing the tiered levels of approach that the whole system has. I think that's really exciting to see that coming into play. I'm wondering if you can tell us a little bit more about Fast Forward. We've sort of touched upon it a little bit. Could you tell us a little bit more about it? One of the maybe most exciting things is, or for us on the outside, I don't know how it feels from the Bureau, but is the sort of rapid growth and the really big sort of boom in the reach of it. And so I'm wondering if you can tell us a little bit about the program and tell us a little bit about, how the initiative's expansion is sort of being handled at the Bureau.
So we have so many partners. We may hold the contracts and have the system connections, but we have worked from the very beginning with the UNH Institute on Disability, and implementation science has been integral in ensuring a slow and steady, successful rollout. One of the most frustrating things that we see is legislative support for something. We get some money, we're told to do it right away. We do something quickly, and then 2 years later, the budget changes and that program stops. So trying very intentionally to not have those stops and starts in programs, and to have that slow and steady design so it's successful for every family as we're growing. Like I said, when we did our first state plan amendment, we projected serving 150 families a year. When we updated it this year, which we're pending approval right now for July 1, we've estimated 500. We're serving more than 500 point in time. We've rolled out 2 care management entities, but essentially Fast Forward is high fidelity wraparound. So it is care management. It is not a clinical service, but the coordinators are going to be ensuring that families are ready for and connected to those clinical services. So an individual may be enrolled in Fast Forward. The goal is to have intensive in-home supports to avoid institutionalization or removal or disruption in the family, and to connect with all of the clinical supports and other supports needed. It's individual and family driven. It's based on the team coming together to make the plan. It is not something that is given to you. It is not a cookie cutter formula on how to make kids' needs. It's a model that families come together and have those conversations, and the individual gets a voice on who they want on their team, who they find supportive, what they think will meet their needs, emphasizing strengths. So making sure that the things that the individual is successful in are part of that plan. If they're successful in music or sports or other community involvement, that becomes a key part of their supports and isn't eliminated because they need to go to therapy. No, it's also a big part of what is making you successful and whole. And so the model includes the high fidelity wraparound and the planning, access to youth peer support, access to family peer support through NAMI. Frequently, they are the first people to talk to the family. Once they have applied and are approved and are accepted into the Fast Forward program, then they're connected with that family peer support to start, to help them have someone to talk to about going through the process. And we have the ability to use funds for customizable goods and services, things that aren't otherwise covered or met by Medicaid, to reduce those barriers to engaging in treatment and successfully planning. It's a 12 to 18 month model. One of the things that we have been doing with the system of care is really focusing on collecting data, using those universal strengths and needs assessments, and having the ability to track is what we're doing working over time. So we have a contract, and actually a subcontract for a systems assessment that the first one will be released in the coming weeks. The second one is already underway that looks at are the services we're providing evidence-based? Are they being done right? Are they being done with the right? Are they being done enough? So if the fidelity is X number of hours, if we're only doing 2 hours and it should be 10, is that really going to meet the needs of families, or are we diluting it so much because of capacity issues that we're not getting what we want to get? So tracking all of those metrics on the families engaged in Fast Forward, we've had great success to show that if they successfully complete the 12 to 18 month model, they're not coming back. They're not going to the emergency departments. They're not going into residential. They're able to successfully maintain in the community because they have a plan when things get difficult or something unexpected happens. They know who their natural supports are in the community. So they're not coming back to Fast Forward. They're still engaging in supports, but they're able to manage as a family. And so we really want to make sure, as we have more experience, that we know these are working, that we're investing in the right things. And our pilot program in our first 5 years, we've very much shown that. As the sample grows, it's going to be really exciting to see how that rolls out in the future.
I'm all about that. As a researcher, I love the commitment to the evidence base and sort of the tracking and monitoring outcomes. I think that's so exciting and just really practical way to approach these kind of testing new strategies. One of the really great questions that we just received from Tori Jennison asks about some of the systems connection. So Tori says, children in behavioral health crisis impact and are impacted by family systems. Could you share any insights about efforts at the state level to support coordination of services for families for kids receiving care? More funding for systems to support parent peers, brief behavioral health intervention for parents from counselors in primary care, support groups, family resource centers. When children are no longer connected to an organization, that advocacy and support often evaporates. Need air traffic control entities.
Yes, yes, we do. And I think we're trying to build some of those. So for families that are receiving tier 3 services and those intensive in-home supports, that is that air traffic control for that family. And it's very intentionally built that way, and hopefully takes some of that pressure off of a parent needing to step out of work to make 10 different phone calls to 10 different places to connect 10 different things. And then when you map out all of the different things that the family is connected with, they're going to 20 hours of appointments a week. I mean, families can't sustain that. So when they're already in crisis, that's just overload. So for that level, absolutely. I think there are different parts in different places, and one of our jobs is to bring that all together. And we are trying very hard to do that from a number of different directions. DCYF involved families have access to a few different things, but we're standing up the community navigator program through DCYF that's going to help families that are sent to DCYF but aren't DCYF appropriate to make sure that they do get back to the right supports and services in the community when they are not involved in abuse and neglect or juvenile justice, but they are clearly demonstrating needs. It's important that we don't say it's not abuse and neglect, so not this door. So there's a lot of work over there standing things up. There's a lot of integration with our family resource centers and home visiting, and depending on the age span where that is. But we know we have a lot of work to do. A lot of what we've built is brand new. And we don't have all of those pathways. We have the Children's System of Care Advisory Committee that meets regularly. That's a place that a lot of providers come in and share what they're doing and how to connect with it. We're really excited to launch the Children's Behavioral Health Resource Center that the UNH IOD has been helping us build, which will give, it has two components. One is focused on professional development, training, technical assistance, enhancement of access to evidence-based practices. But then the other side of it is the family navigation side and search tool that will really provide explanations of the different parts of the service delivery system and how to connect with them. On a higher level through Medicaid and other parts of the department, looking at really the event notification systems and different ways that providers can naturally and automatically connect to know when an individual discharging from a hospital is going back to the community mental health center or their primary care provider. There's a lot of work to make those connections in different ways, but we as the Bureau hope that we can pull all of that in to also explain that in an environment that's focused on children's behavioral health. The other exciting work is that we received a federal grant to pursue certified community behavioral health centers, CCBHCs. I usually don't say the whole thing out. That really is a national trend and will look at our readiness to change the way that we provide community behavioral health services, including further integration into primary care, as well as CCBHCs have to be engaged in the crisis system and serve a broader population than our CMHCs currently serve. So right now, you have to, for a child or youth, you have to have a diagnosis of a serious emotional disturbance. You want families and young children supported before that. The CCBHC model would include that earlier, more run-of-the-mill or more average access to that entry level mental health care and prevention and screening, and serve everyone on a more community-based level. So we're going to use that grant for the next year to study our readiness, to look at how it would impact the payment structure, look at how it would impact workforce and what the expected outcomes would be. But by expanding the CCBHCs, that would bring in a lot more of the population and make sure that that integration is happening with the rest of the things in their lives, including education and childcare. And primary care. So that's exciting too.
How exciting. Yes, congratulations on the grant. That's really good news and great to have the support for that planning and that examination process, which isn't always available, but really does represent a big chunk of the work to be done. And so it's really nice to see that being supported so that that can be done, carefully and thoughtfully as you do at the Bureau. Speaking of that sort of connection with education, childcare settings, we have a couple questions in the chat. Dennis asked, does your Bureau do outreach to groups like Head Start programs?
We do, or our partners do. So we have different integration teams within the department, including the early childhood integration team. I sit on the pyramid model state leadership team. We have one individual that is dedicated to our infant mental health. We are starting to have the high fidelity wraparound for that population, and she certainly does engagement. But we also rely on our partners because part of the care management entity contracts include provider development. Part of the TEA center includes that technical assistance and provider development. So where we only have 9 people, we have a lot of moving parts and new information right now. We do try to focus on larger groups and statewide forums. And then partner with other folks who are in the field providing services to continue those more local connections. But we recently did do a presentation with a couple of the Head Start programs, and so yes, but if it's not us, we will try to connect folks with who's appropriate in their community to do that.
Yeah, that's great. That helps to sort of build that umbrella of outreach to do that through that partnership network. Michelle asked in the chat, you mentioned the important role of schools in the process. Could you talk more specifically about how school-based referrals and treatment work and how this may have changed over the years?
Sure. I think overall, it has improved dramatically. We have Choose Love rolled out throughout the state. We have a number of different task force and work groups that we're part of looking at schools. The system of care law includes both HHS and New Hampshire Education Department, and there are a number of different system of care programs within different schools. Schools are choosing to engage and support things as they have capacity. And so some are far more robust than others. I think that we have come a long way just in the last few years with the system of care. MTSSB is great. There was some additional funding for that in the budget that we weren't sure if that was going to happen this year. So that's nice to see that some of that will stay in place within the schools, which is another tiered system of supports to look at screening and supporting everyone and identifying higher levels of need and making sure we're engaging. Our community mental health centers have a lot of partnerships with different districts. There are a lot more embedded professionals in schools now. My poor son's school, I have a kindergartner, and we do have an embedded CMHC individual in my son's elementary school, and I show up with lots of questions, but have been so thrilled and excited to see the work that they're doing to really have it just part of the fabric of the school. And it's not counseling, it's not high intensity mental health services. It's focusing on wellness and the basics of prevention, and only diving in deeper when needed and when families agree and are open to it. But I think the opportunities are there, the conversations are there, and we have a lot of room for growth. But, one of the indicators of some of the successes in different communities, unfortunately, is that people have left community mental health center jobs to go take the school jobs because they're great jobs and they're enjoying them. And while we still need our community mental health centers to be fully staffed and supported, seeing those other opportunities for professional development and the early prevention and success in our communities means that we're going to have a healthier population later and hopefully need less of that higher intensity supports and services. So I think that the system of care was a huge start to integrating, and I think we just have so much opportunity to continue to build on that. One of the other places that we've seen some of that connection develop is while we've moved away from requiring a court order for residential treatment and focusing on episodes of treatment rather than placement, there was a gap because the law for special education relied upon the court order for educational services. And so as we started serving more and more, and we have about 70 youth who we're supporting who are not court involved right now, it's a bit of a challenge for the districts who have the responsibility for the IEP, but the child needs treatment, and how do we make it work together? And this year, the legislature amended that language to include our episodes of treatment if they're approved by us to support the education from the Education Trust Fund and put some money into that so that schools don't feel the pressure when a youth needs to step out for treatment, and we can all coordinate on their IEP as they return back as quickly as possible. So both on kind of the early prevention end and the deepest end kids that need to step out to have their needs met for a short period of time, we've seen a lot of improved support and collaboration, and we learn a lot as we make changes and have to adjust. And that's one of those areas that it's exciting that this budget includes a reflection of that.
I see a lot of that collaboration really embedded in the approach of the Bureau right now. One of the things I thought was really interesting was when you shared the graphic of the organizational structure and the connections between the Bureau and the broader division. Those other sort of bureaus that are nested underneath really do kind of encompass that more life course approach, that recognition of these intersecting, areas. And I wondered if you could say anything about what that process has been like for you as a bureau to sort of, integrate with DHHS to make those kinds of decisions more broadly as a division, and to sort of work together when I'm sure everybody is short-staffed and, understaffed like everybody, and typically often at the state as well. And so, what has that process of intentional collaboration been like inside the Bureau?
Sure. So for us, that's how we started. We started as a collaboration with the Children's Behavioral Health Collaborative that was the department and a number of different stakeholders, providers, and advocates. So I think we come by that very naturally. We also don't have a history of, but this is how we used to do things. And so everything is new for us, which is that clean slate is a great opportunity. For me personally, having come from representing the whole department and other state agencies, I think I naturally say, but so-and-so is doing this, or did we talk to that person? And I want to be as efficient as possible because I don't want to do something twice. A lot of our contracts are joint. So our community mental health center contracts have the adult and the children components. We don't have separate contracts. Some things are universal and some are called out for children's services and some are specifically for adult services. We have more and more that we are including in the same contract and we're developing it together. And the implementation teams have members from all the different bureaus. And then the same is true outside of our own division with our work with the Child Development Bureau or public health. It goes far beyond just what we're doing. Somebody has to own the contract, somebody has to be responsible for it. But we're looking to partner with public health on further development of the Children's Behavioral Health Resource Center, because they're also working to ensure that the primary care workforce understands what's available for infant and early childhood mental health, and you don't need to do it twice. So I think for this group, it comes really naturally. It also takes a lot of time. So meeting schedules are very, very tight. And it's not always as fast as people want. There's an expectation of, we gave you this money 6 months ago. Why don't you have it fully developed, implemented, and staffed? Because we're thoughtfully thinking through how it's going to impact the rest of our service delivery system. And then we're identifying exactly what it needs to include and who our best partners are to stand things up, to not have unintended consequences on the rest of the system. So I think the more people you bring in the conversation, the more complicated it gets, but it's also a better result. And so it's that push-pull.
Yeah, and really speaks to how you build those systems that are sort of sustainable and wide-reaching and, really are feasible for people to sort of participate in and lift up, is that thoughtfulness, that planning, that partnership that goes in the beginning. But of course, as you said, it also means that it's not moving lightning speed always, but moving forward, having those processes be collaborative, having those processes be thoughtful, really does seem like the way to go when building a system from, essentially from the ground up to really make sure that we're serving those children and families through the longer, broader life course and through those tiers of service needs.
Yeah, and I think just to also add, as I talk about stakeholders and other providers in other parts of the division, I want to make sure that I reemphasize and hearing from peers and families throughout. And we need to hear from them to make sure what we're delivering is going to meet their needs. So as part of that implementation and that intentional development, that voice is just as important as the voice of the individuals who are paying for it and the individuals providing it. And so it does take time, but I think that what we've shown with Fast Forward and some of the other things that we're building is families are feeling heard and feeling like these new endeavors are meeting their needs in a way that they weren't finding before.
That's what it's all about, right? I mean, what's better than that is hearing that from families and from those folks that are being served by those systems. That's got to be as good as it gets when it comes to the implementation. I wonder if you can, like, forward looking, tell us a little bit about, what are you most excited about? What are you most hopeful for? What's on your radar for the future? If you can look out into the future, I know you all have been busy, but looking ahead.
Yeah, absolutely. So I think one of the things that I said when I took this job is, well, number one is not to break it. It's not fully implemented yet. We have a framework, we have a plan. What we need is continued support and continued partnership, and to really build it out to be able to measure, is what we're doing successful? Is it meeting the needs in an efficient and cost-effective way? And so have we done the right things? So looking forward, we are going to be doing a lot of continued development of each of the services and systems that are very young, a lot of data work, a lot of system assessment, but then also modifying as necessary. We have some new charges on the mental health, on there's some money in this year's budget to look at specifically mental health evaluations and services for youth. There's about $1 million to stand up something there. The money to look at peer-to-peer grief support for children who've experienced the traumatic loss. So it's refining, it's closing the gaps, it's making those connections, it's making sure people know what's out there, and then building out the crisis model more. So the crisis certification, the crisis centers that we're going to build, and then continuing to focus on the transformation of our residential, ensuring the lengths of stay are as short as possible, and the integration is happening as children and youth are coming back to the community and school. So there's a lot of smaller initiatives, and then staying the course on the big initiatives to make it more robust, to make it accessible in every part of the state, to decrease wait times, and of course to ensure that there's adequate workforce and professional development to meet those needs.
Great, and what an exciting time to see so much of this coming to fruition, to see the reach really landing and really getting to those kiddos and those families that really need those supports, and doing it in a way that both really helps them get where they're going and is sustainable. Really creating a system for the state it's really exciting to watch. We don't have any additional questions in the chat. I'm wondering if you have any parting thoughts that you want to share, anything we didn't cover that is important to touch on.
So let's see. I mean, I think what I just said is the most important, that it really isn't its infancy. Transition to a system of care is a long process. Other states that were ahead of us will really say to see the outcomes and to see the full development of the system is more the 10 to 20 year process. These are not things that we're doing in a year or two. So that continued commitment to the process is extremely important for all of us, but also that we are looking for everyone, everyone at this meeting and everyone in this space to see themselves as a part of the system of care, to be committed to the system of care values, and to help us figure out where those gaps are and where those needs are and how to better integrate, because there is a lot of work to do. And while we're really excited and proud of a lot of the work that's happened, we know there are unmet needs and we know we have a long way to go. So I don't want to minimize that there are families that are feeling frustrated right now. And we acknowledge that and are committed to continuing, but we know it's out there. But what we also do see in the data is New Hampshire is not different from the national trend, and that needs have gone up. So where it feels like there are less providers and less services, we know that's not true. It's just the need has gone up that much more that it doesn't feel like it for those families that are feeling unsupported. So we are just going to continue plugging away to try to close those gaps and
That's a great point and a great reminder for us all that, it can be both, that we're seeing this progress, but also there are these, elevated unmet needs. The data show that there's no question there that that is a trend that is New Hampshire is part of, but that it's not New Hampshire specific. And so a good reminder that we're, on a good path, but still work to go. And I'm really excited to have had a chance to talk with you today and to pick your brain. What a pleasure to be able to have some time to chat. Thank you so much for coming, for answering everybody's questions. And I look forward to staying in touch and seeing what's up next for the Bureau. Thanks very much, Rebecca.
Thank you for the opportunity.
Thanks all. Thanks for joining Coffee and Conversations all. We'll talk to you next time. Bye-bye.